Okay, as you heard, we are recording. You'll get a notification. Welcome, everyone. My name is Nico Jansen, Senior Health Policy Analyst with the Office of the Insurance Commissioner. This is the Palliative Care Benefit Work Group. If you're looking for the palliative care meeting, you're in the right place, and thank you, everybody, for joining. We're going to start off today with our land acknowledgement before getting into our agenda. We are meeting virtually from Olympia and Tumwater on the traditional territories of the Coast Salish people, specifically the Nisqually and Squaxin Island peoples. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress by the Coast Salish people in 1854. The OIC in Washington State employees respect these lands and tribal sovereignty, and we acknowledge the tribal governments and the Coast Salish people living on and taking care of these lands. Okay, well, welcome back, everybody. It's been probably about a month since we've last met. I'm glad you're all here. Thanks for making the time. Our agenda today is twofold. Number one, we want to give a little bit of time to do a recap of the comments and feedback that I received and sent to Milliman from our last meeting. And as a refresher, the feedback and input we received was out of our last meeting's discussion, largely on the eligibility criteria, as well as the included services, and then some additional discussion on the staffing issues. So we had asked the work group members, our partner agencies, to give us feedback, and I'm going to give Milliman some time to discuss that today. The second item on our list today, and what will likely be more of the bulk of today, is for Milliman to talk about the payment models aspect of this work. We welcome discussion today and questions. Milliman has a written product that I distributed, albeit in short notice for this meeting, and I appreciate your understanding with that on our tight time frame. I've distributed that. That's in the calendar invite. They're going to discuss that. And in addition to today's discussion, we're giving the work group members and interested organizations 2 weeks after today's meeting to send us additional written comments, reach out to me with questions on the payment model specifically. Okay, so that's our agenda for today. As you may recall, our final product, our final report is due to the legislature on November 1st of this year. And between now and November 1st, we're having this discussion about payment models today, and then there will be a future work group meeting, likely late July, early August, regarding Milliman's initial actuarial analysis. And then we will have likely a future work group meeting to talk about the draft report. So those are really the kind of 3 big phases between now and the final report. So that's our agenda. And at this point, I'm going to turn it over to Matthew and the Milliman team to begin with discussing the feedback that we had received.
All right, sounds good. Thank you, Nico. And apologies in advance. I'm fighting a bit of a cold, so if I cough a bit or sound a little off, that's why. But we wanted to start today's discussion by going through some of the feedback items that the work group had sent us. Some of our responses, they range from some of the larger items we want to spend a little more time on to just going through a list of things just to make sure that we're addressing all of the items that were brought up. So of the feedback points that were brought up, the biggest one from our discussion, I think, related to the pediatric population, basically everybody under 21 who in our original discussion was not going to be included. So what we have updated is we've created a new model to include the pediatric population. One thing I will note is that there will be significant differences between this model and the one we've discussed for the adult population. In particular, 2 really notable differences are, first, there's going to be a single tier instead of 2. And then second, we are not going to require the same significant functional limitation and unscheduled healthcare utilization requirements that we will have for the adult population. We'll provide some additional detail around the particulars of the model when we have the draft actuarial analysis ready. But I wanted just to make everybody aware that we have taken that into account and we are building that into our modeling. Couple of other points related to the modeling that I wanted to draw attention to. First, in terms of functional status limitations, there are a number of other items that were covered in our first report under quote unquote other status limitations, such as cognitive, language and memory deficits, treatment for pressure ulcer, and care-related enteral feedings. We'll have additional technical detail in our actuarial report on all of those processes, but we do note that importantly, we are only able to use indicators that are available in the claims data for our analysis. That does not necessarily preclude the state from choosing to use other or additional indicators, but does preclude us from analyzing the potential impact of unknown indicators. So if you've got some other data source, the certification, et cetera, there could be differences between what we model and what the state eventually goes with, but that is a necessary limitation of the type of modeling we're able to do. Third point I wanted to bring up is relating to reevaluation. This process can vary across palliative care programs. In our original draft report, we noted that we were talking about a 6-month reevaluation. The most common approach for this is to require this for every 6 months, including continued eligibility for each of the components. However, we do intend to include in our actuarial analysis testing around this, in particular, the potential impact of excluding any requirements around inpatient and ER utilization. Since one of the goals of the program is to try and reduce utilization, we do want to see what it potentially looks like if we start editing our criteria to allow that to not be a required item for reevaluation to be eligible in 6 months, 12 months, 18 months down the line. Moving on to a few other points, it was noted about goals of care and ACP. We have decided to increase the service frequency for every 6-month period to 2.5 for both tiers 1 and 2. So that will be an update. A few other those were probably the biggest points that I wanted to get through. And again, we will have technical detail on all of these in our actuarial analysis, so you'll be able to see the detail. But I just wanted to walk that through with you all live. A few other points were, first of all, the work group had suggested to modify the definition of palliative care for what was used by the National Coalition for Hospice and Palliative Care. We will include that in our future reports. There's no problem with doing that. For rural population modeling, there were some questions around there. I wanted to clarify that what we're doing is we are not limiting services to specific provider types, as palliative care team members may very well differ across geographies, and I think that's normal. Again, there's certain restrictions around availability of providers, and I think that flows through to the overall analysis, and that is a consideration we want to continue in our work. One of the work group members had made a comment about having a palliative care clinician review our report. Our understanding was that the work group included members with deep subject matter expertise on this subject, but if that piece of it is missing, we're happy to have a conversation around there. Another point for the utilization table, the estimated service cost for initial assessment was based on 55 minutes rather than 15. I think there was a comment or a question that indicated they thought it was based on 15. In our data, the only services that are billed in 15-minute increments would be spiritual care needs, although I do note we do intend to increase the utilization there to 6 units or 90 minutes for tier 1, 10 units or 150 minutes for tier 2 across the 6-month period. Similarly to one of the other points, the work group asked about team members who do not typically submit claims, providers such as social workers, nurses, spiritual care professionals, etc. Our clinical team had considered the typical care team when identifying codes used to proxy the estimated cost of each palliative care service. I don't think that's necessarily going to be a perfect one-to-one match, but I do think that's going to be pretty broadly reasonable. And again, once we have the actual data and we start processing it, we'll be able to do some more evaluation on what we are seeing in practice. A couple of other items in terms of changes not made. End-of-life care was brought up as a point. Our understanding is that this is excluded from the scope of both our analysis in this project, as well as what the state intends to offer, in that end-of-life care and hospice care are considered separate from what we are doing here. So we have not made any adjustments for that one. The other item was around care coordination. There was a question around there. And I would just note that care coordination was in fact included in our modeling, specifically around ongoing management visits, which were 6 for tier 1, 12 for tier 2, as well as 24/7 telephone support and other services. Excuse me. I think those were the critical points that were being brought up by the work group questions. But if I've missed anything, please feel free, or if you'd like to have a follow-up on what I've just brought up, please feel free to chime in, and I'm happy to give a little bit more information if helpful.
So thank you so much, Matthew. That was quite a list. We appreciate the consideration, and I also appreciate how detailed a lot of the work group members were in giving comments. And Trooper, I can see you're battling through today to help us. One point I want to mention is that some of our feedback was the numbers originally in Milliman's report on the utilization table to some folks looked a bit low. So I just want to, I guess, emphasize that my understanding from what Matthew presented is they have adjusted some of those numbers. At this time, I want to open it up for any quick questions or comments on what we had covered. And I also want to note that if there's kind of an extended discussion or more detail to get to, we can absolutely follow up. So opening the floor now for any questions or comments on the feedback and then how Milliman is approaching that. Raise hands or just unmute. Yes, Dr. Fausto.
Thanks for the overview. I think I've been talking to colleagues in other states who've enacted benefits of this nature, and I think one of the takeaways, I don't know where exactly it fits, but I feel like it's important to raise, is they mentioned two challenges they've faced is once the benefits are enacted, you need to build teams and advertise. And there's almost like a ramp up that is different from steady state. And so I'm wondering if there's any actuarial process that could be taken to think about what does the first year of a service look like versus ongoing? Because it's, it takes more to build the team and to staff up and to advertise a team versus a team that's fully functioning and thriving. So I don't know if that's maybe outside of scope, I recognize, but just wanted to
No,
put it
that's a
out there.
fair question. I mean, it's probably outside the scope of what we were originally considering, but there may be something we can do in terms of a year 1, year 2 ramp up. I don't have a good answer off the top of my head. I'd say we'll take it back and think about that. I don't know off the top of my head if we've got a good data source to estimate that. I'd be a little hesitant to just plug in an arbitrary factor off the top of my head, but there may be something we can do in terms of research. I think you said you had colleagues from a couple other states. If they've published reports on those or anything like that, we'd be happy to take a look. If there's something at a high level we can potentially do, it's at least worth considering. I just don't have a good answer off the top of my head about how doable it is to do something complicated, or if there may be a high level thing that we can do that would enhance this.
Sure, I can definitely forward some content they sent my way.
Yes, thank you.
That'd be great. Thank you. Go ahead, Barb.
Yeah, just regarding Matthew's question about whether our work group has palliative care experts. I know that my colleague Leslie Emmerich, who's not on the work group but is attending, and whenever we have a question, we reach out to Dr. Greg Van de Kieft. And I know Mara, as a nurse practitioner, works in palliative care, and Dr. Fausto works. So I think there is some expertise. But getting back to Dr. Fausto's question, I think none of us has a huge amount of expertise in providing home or community-based palliative care, although Dr. Van de Kieft may disagree with me. But I know from hearing from colleagues in other states, it's hard to keep a palliative care program solvent on a totally just on a fee-for-service model. So that's just what I've heard anecdotally. But again, I don't claim to have a ton of expertise. But I know people. I know people who do.
Yep, no, I think that's a fair point. And one of the things that we're getting into relates to the payment models, where we don't want to just say fee for service and we're done. We do want to think about alternative payment models. If your colleagues have some additional anecdotal data about what they think has worked well versus poorly, we're always happy to take a look at that. And we're going to get into some of the details later in our presentation, or later in the discussion rather. But one of the things that potentially may impact this is if we get into risk arrangements, not just on the palliative care service, but on the total cost of care that have certain targets around some percentage point reduction, whereby palliative care providers are taking on risk beyond just the services they're offering. That's something which has the potential to impact the overall cost of this program. Although my cautionary note would be that you can't really force providers to take on capitation risk like that. So it has to be, so we can talk about what this can look like potentially, but I wouldn't want to make an assumption that says automatically they're going to take this deal or we're going to do something really favorable. But we can have some discussion around what that could potentially look like and what some of those potential financial impacts are. That's one of the considerations we want to make sure is included in our actuarial analysis beyond just what is the straight up cost of the program.
I'll just echo Barb's comments. I feel like I have a lot of expertise on inpatient palliative care, but community-based palliative care is a very different format. And I appreciate Matthew and others that your reporting really seems to be geared towards the community-based model, which is where I think we need to move for this.
Thank you. Appreciate the comment.
And I really did it just to give you a moment to cough there.
Also appreciate it.
Good and compassionate position. Thank you, Dr. Winnipeg. And yeah, I would just add in terms of the piece of feedback on having palliative care experts review, I do think part of the rationale for having this work group is to have a lot of clinical expertise. And I think having said that, we are doing a process that's inclusive, and if folks have interest in this work, want to consult with us, we're open to that. So I do think we're getting, in addition to the work group, the opportunity for, folks who have expertise and interest to be able to consult with us, give us feedback. We're very open to that. So I would say, anyone in the work group has those types of individuals, just feel free to reach out to me. I think we hit on a really good segue to get into the payment models, but just pause for a moment to see if anyone else wanted to bring up something about the feedback or just a note for future discussion. Okay, if anything comes up, you can let me know. For now, we're going to turn it over to the payment models.
All right, Sherry, perfect. You've got the screen share open. I'll let you drive.
Sure. Okay, can everybody see that okay?
Yes.
I can see it.
Awesome. Thank you very much. All right, nice to see everybody again. So as a refresher, in April of 2025, we gathered to discuss the initial draft report, which included the clinical eligibility, included services, appropriate staffing, training, and evaluation criteria for the adult population. And based on that feedback, as Matthew stated, we expanded the scope to include individuals aged 20 and younger in the palliative care model design. So the benefit that we're talking about now is going to cover both adults and children insured by Medicaid or commercial insurance who have a serious illness, are not enrolled in hospice, and are not covered by an existing palliative care benefit. That's our intended population that we're continuing to discuss today. The purpose of this second draft report that I have on the screen is related to payment models. And there's a few things that I want to touch upon before we dive into fee for service versus periodic payment and the specifics of a payment model. The first is really the landscape in the state of Washington. Currently, the Apple Health benefit covers hospice services for adults and both hospice and palliative care services for children rendered by state licensed hospice agencies. Apple Health defines a hospice agency as a person or entity administering or providing hospice services directly or through a contract arrangement for clients in places of temporary or permanent residence under the direction of an interdisciplinary team composed of at least a nurse, social worker, physician, spiritual counselor, and volunteer. So when we're talking about palliative care teams, that is the current definition as defined by Apple Health. For hospice services, Apple Health is reimbursing this hospice agency through a hospice daily rate, and the pediatric palliative care services are covered per contact, up to 6 palliative care contacts per client per month. And so I wanted to kind of set the stage with what the current landscape is for hospice and palliative care providers and reimbursement in the state, and kind of open it up before I proceed with, do you have any current concerns about the existing landscape related to compensation for these providers, adequacy, availability? Wanted to get your feedback there before proceeding. And if there's none, I'll just continue.
For our clinicians or our providers, any input? I mean, I know we talk a lot about the lack of palliative care access and provider workforce challenges, broadly speaking.
Are we specifically talking about pediatric palliative care at this point?
Really, either any current concerns or anything that you think of when you think of the current services provided and the hospice and palliative care agencies that are in the state currently.
Go ahead, Barb.
Yeah, I don't know if this applies to this topic or later when we talk about provider eligibility, but currently in the state, the current pediatric palliative care benefit, you have to be a part of a licensed hospice to provide that care. And so home health agencies cannot provide it unless they also have a hospice. But if it's a standalone home health agency, they can't provide it. And I know you again talk and later in the report talk about provider eligibility, but I would hate to see a limitation into, you have to be a hospice, or you have to be a home health agency, or you have to be part of an outpatient palliative care clinic. It would be nice if the benefit was available to anybody who was licensed. And again, we're going to talk about that more later, but I do see that as one limitation to the current palliative care landscape in Washington State. Thanks.
Great, thank you. That's helpful.
Dr. Fasto, did you have a comment?
Yeah, I would just add, I think if we're trying to use expansive in scope of providers, I'm not sure that the language I'm reading covers APPs well, especially like NPs or PAs, because those might be the resource that's available in a more rural setting. And so I would include language that is, includes APPs. That's possible.
Great. And we are going to get more into the providers eligible to render these services, but thank you for your feedback, and that's helpful. Okay, great. So in the previous call, we reviewed the adult clinical eligibility criteria and included services. And as a reminder, those were in alignment with the Berea Collaborative. This criteria included a diagnosis of a serious illness or multiple chronic conditions, functional limitations, and recent unplanned acute care hospital-based utilization. Matthew had mentioned that just before. As we discussed, Milliman has also prepared clinical eligibility criteria and a set of covered services for individuals aged 20 and under in alignment with the Apple Health clinical eligibility requirement. The intent of this criteria is to identify a population of individuals under 20 and under, that have a life-limiting medical condition with a complex set of needs requiring case management and coordination of medical services for at least 3 of the 6 circumstances from the bulleted list. So right here, to be eligible for, I'll call it the pediatric palliative care model, the individuals need to have an immediate medical need during the time of crisis, coordination with family members in more than one setting, life-limiting medical condition, a medical condition in which the family is unable to cope, a family member who needs additional knowledge or assistance, and therefore their therapeutic goals are needed to improve quality of life, comfort, and family stability. So as currently written, we're going to model the Apple Health criteria. And there's one thing that I want to mention to the group is that the Apple Health criteria does not cover palliative care payments if the individual is receiving similar services from home health or other disease management programs. And I'm not certain how many individuals would meet this criteria that are also receiving home health or disease management programs. But in our modeling, we're going to flag and exclude those individuals that are receiving similar types of services. And so I want to pause and just make sure that you're okay with that, and that is kind of an operational consideration that the work group is comfortable with.
Yeah, go ahead, Barb.
Sherry, could you repeat the question you just asked? I want to make sure
Sure.
I got it, and then I do have a comment.
Absolutely.
Thanks.
So the current Apple Health criteria does not make a palliative care payment if the individual is receiving home health or services rendered through like a disease management program. And so as written, children, pediatrics, individuals 20 and under are that are receiving those services would not be eligible for the palliative care benefit in the modeling exercise.
Yeah, so the issue I wanted to bring up, and I know Leslie Emmerich and I talk about this frequently with our colleagues at Seattle Children's Hospital, is for hospice care, the Affordable Care Act does require concurrent care. So if a pediatric patient is going on hospice, they can also pursue curative care. And so it brings up the question if the palliative care benefit would allow the parents and the child to continue to pursue curative care while they're receiving palliative care. And that's true, I guess, for adults too, can they pursue curative treatment while also receiving palliative care treatment? That's just confusing in my brain. And I don't want to confound hospice care with palliative care, because I know we're not talking about hospice care, but it still begs the question, and it is a question that will come up for patients and families who are considering whether they should receive palliative care. Will it preclude any sort of curative care? So I'm just sort of throwing that out to the group at large.
So as we have moved through the modeling exercise, individuals that are receiving hospice are not eligible for the palliative care benefit. So if
No,
they're
I'm actually sorry, I'm not talking about that, but can they receive palliative care while also receiving curative care, chemotherapy, say?
my understanding is yes. Carol,
Okay.
feel free to jump
Yeah,
in.
there's no preclusion of that. It certainly in terms of the modeling we're doing, or in any of the recommendations that we've used to sort of develop the benefit specifications. So there would be no limit on the patient's ability to pursue curative care, whatever treatments. I mean, I think obviously the expectation is in some cases that patients might, receiving palliative care, make some different choices, which could result in some changes in their pursuit of curative care, but there's certainly no limitation on their ability to pursue curative care.
It's also consistent with the definition that's used in the bill that authorized this work group, which I think came from the national definition of palliative care. So
And I defer to all of my colleagues who have their hands up because they know this more intimately than I do.
Yep, we have a little bit of a line here. I think, Jim, I
Yeah,
saw your
I
hand.
just,
I'll get
if
everybody else. Go ahead, Jim.
I'm understanding the question, I just think, and home health can represent so many different things, but often it's like hands-on, like washing, bathing, care kind of stuff, and DME and things like that. And the palliative care benefit is not like, it's pretty clear, I think later on, it's not DME, it's not medications. And so I think these are two different things, and one should not preclude the other. So if there's any way that, like, I think they're supplemental and additive if they were offered together. But a lot of what the palliative care benefit is sort of cognitive work around goals of care and thinking about what one needs. But it doesn't seem like it's resources of like, gonna help you get a bath today and things like that. And so I think these are very different things, and we should do the best we can to separate them and acknowledge them and not have them be either or. Thanks.
Thank you.
Jennifer, did you have a thoughts?
Yes, I also agree with that statement that home health is very much different. And then I just kind of wanted to dive into the second. Did you talk about disease management? People would not, they could not have both disease management and palliative care. Did I misunderstand that?
No, so this is not Milliman's recommendations. These are we are following the clinical eligibility requirements set forth by Apple Health. And so in alignment with Apple Health, that is one of the parameters that they have stated is that a palliative care payment will not be made for individuals receiving disease management services. So if that is something that you don't want to align with and that you want to keep your eligible population broader, that's something that Matthew and his team can take into consideration with his analysis plan. But I wanted to bring it up because it would exclude many potentially eligible individuals.
Yeah, and I would also say that those are also two distinctly like those are also different. And would like my recommendation would be that palliative care is different than disease management. There are some similarities in some of the services that they provide, but palliative care is much more encompassing of a whole person care. So I just wanted to get my 2 cents in.
So I think the only population for which this is relevant right now is the only population that has a palliative benefit, which are children in Medicaid. So a recommendation for a more expansive benefit would essentially add the benefit in its expanded form to the total population and then also expand the Medicaid benefit. I mean, I certainly understand the clinical issues you're describing about sort of the different nature of the benefit. I think there is like the sort of underlying assumption that if people are getting, home health services, for example, they might be getting chronic care management services or complex care management services as well. And so like together, all of that would, with the additional palliative care benefit, might create a lot of providers involved in care management. But I can understand the distinction you're making. And so we were just picking up on, again, the Medicaid current requirement for palliative care, but certainly can drop that. The consequences of that is, again, an expansion of the Medicaid benefit for palliative care that currently exists for children.
Okay, we have a message from Heather from HCA. And HCA is on this work group, and we've been closely coordinating with them and getting feedback. She says, clarifying that Apple Health billing guide prevents payment for duplicative services. I think this is also a point where, as you look over this document and think about it, you can send us some more written, suggestions. Ultimately, we have a few more hands up that I will try to get to quickly here. Let's see. I see Gray. Your hand is up.
Yeah, some of the earlier speakers addressed what I wanted to address, which is I also would concur that we need to be expansive. I understand we don't want to pay for duplicative services, but I just spent an hour over the weekend with an occupational therapist and a speech and language pathologist working on a proposal on how therapy should be coordinated within palliative care, because many of our patients are no longer rehabbing, but OT, SLP have an important role to play in optimizing function and quality of life for our palliative care patients. So anything that would preclude the palliative care benefit for people who are on home health for those type of specialized therapies, I think is going to be very limiting for what our goals are. And then secondly, the element of, well, let's see, my brain's sliding here. I'm going to just stop right there and let it go. But thank you.
Okay, thank you, Craig. Marcia, you've had your hand up a long time. Thanks for your patience. Did you still want to add to this thread? I know we're going in some different directions, but feel free to.
I don't have a lot to add. There is further language in this document about adults on palliative care accessing home health services, being referred to home health services. So I would agree with the previous speakers, and I'm curious what comes further in this document seems to not agree with what is going on for pediatric patients currently. So I just want to make sure that patients who need home health or care management services can still access those.
And I have a follow-up to that, and I'm talking about a different benefit program now. But if someone is receiving the end-stage renal disease benefit and they're getting dialysis, would they be able to access palliative care? Because many of those folks could greatly benefit from palliative care, and they, even if they have a prognosis of less than 6 months, won't or don't feel they can go on hospice because they have to give up their end-stage renal disease benefit, because Medicare won't pay for both benefit programs unless the reason they're going on hospice is completely unrelated to their renal failure, and that almost never happens. So that's just a clarifying question.
Yeah, and for the actuarial analysis, so Milliman's role may be a little different than your operational definition that you're putting into practice, but we have no exclusions for individuals on end-stage renal disease being precluded from the analysis, so they will be included.
Craig?
I got my thought back, and that was around chronic disease management. Some of our, I work with the Washington Rural Palliative Care Initiative, and some of our highest performing teams very heavily integrate their specialized palliative care resources within their chronic disease management programs. And that level of integration, both in their primary care delivery and chronic disease management, really meets the patients where they're at and broadens the ability to provide these services without necessarily needing to carve them out into a specialized palliative care program. But they need to have the resources to be able to bring that specialty palliative care into their chronic disease management pathways and their primary care delivery. And so the more we can support that, I think the better we'll serve the communities.
That is a perfect segue to our next section related to kind of provider types and who the state of Washington and the work group, wants to make eligible for these services. And so currently the network of hospice agencies in Washington are the ones that provide palliative care and hospice services in the state. However, as you all mentioned, other states do it a little bit differently. So for example, in Texas, home health agencies are licensed to render palliative care services. And while palliative care and the services rendered by home health do have overlap, there are some requirements and credentialing things that we have to think about. So for example, palliative care typically includes around the clock on-call support, while home health care is typically intermittent care. And so whether the providers that collectively you agree you want to be eligible for reimbursement are an existing provider type, or you're going to define a new qualification or credentialing a new provider type. It's important that you establish minimum health and safety standards to make sure that the quality of care and the palliative care services are of high quality. And so what I heard earlier was, a broad, we would prefer that NPs, PAs, home health, and like kind of existing palliative care teams are able to render these services. But I wanted to just pause and ask about licensing requirements and credentialing requirements, and if you all have kind of thought through how you're going to establish a network of eligible providers for this benefit.
So I'll just jump in. As it current stands, Washington State hospice agencies don't have to have an additional license to provide palliative care. And in Oregon, both home health and hospice programs can provide palliative care to non-home health or non-hospice patients without having to get an additional license. California, when their Medicaid palliative care bill passed in 2014, they did add an additional license requirement. And frankly, I can't remember if that's for both home health and hospice, but you do have to gain an additional license. And in Texas, it's just been a nightmare for hospice programs who want to provide palliative care to non-hospice patients because they have to get licensed as a home health agency in order to do that. And that's actually not just a bureaucratic thing. If you're licensed as a home health agency, then you have to meet all of the home health standards and requirements and pass surveys as a home health agency. So it's not just a paperwork thing. It's, you have to have policies and you have to be able to meet the standards. So I would hope in Washington State that maybe a licensure is added, but it does allow home health and hospice programs. And maybe, as I mentioned before, outpatient palliative care clinics to also be licensed to provide this kind of service. I would rather be expansive so that folks who live in rural areas have access to these services. Anyway, I'll get off my soapbox now.
This isn't a fully formed thought, and I would really be interested in Dr. Fausto's thoughts on it as well. But I think if we limit the providers or clinicians caring for patients to only those who are, say, board certified or credentialed specifically, it'll create real workforce challenges. But that needs to be balanced against, I don't just want anybody to step up and say, I can do palliative care, because in the early days, 15, 20 years ago, it wasn't uncommon for people just to step up and claim that they have the skills. So some level of higher level training, demonstration of expertise ought to be built in, but not in a way that's so restrictive that we really create workforce challenges.
Yeah, I would echo that, Greg, and I think I'm waffling on like labels and provider types and wondering like, is an RN, should an RN be on this list of like nurse practitioners, physician assistant, clinical nurse specialist? And then waffling even more, like I think social workers can do some ACP work, but then they can't get into all the medical. And so I think, I think if trying to be as expansive as we can, but then to your point, like how do you make sure that people are qualified? And I guess there are, Schwippen has a certification in palliative care. I don't know if there's an RN certification, but just if we can consider those kind of things and not fully formed. Apologize.
Yeah,
Yes.
HIPNA, the
Part of-
Hospice and Palliative Nurse Association, does have a certification for nurses. Sorry, Maura.
This is Carol Bazette from Millman. I was just going to say it's like worth thinking about. There's an interface with, again, the payment approach, is particularly if you're not taking a fee for service approach, because essentially what you're doing, you're paying whatever entity it is that and that entity you have to be confident can provide the full scope of palliative care services, which includes spiritual services, all kinds of services. And so there's an interface here when we list sort of eligible providers. It is probably unlikely that any single provider alone, provider type nurse, could do the full spectrum of palliative care for the whole service mix, which is why I think probably some of these other states have sort of leaned on existing organizations that have some of those capabilities for like such as hospice agencies or home health. I'm not recommending that, but it does raise the issue of if you're going to sort of move away from established organizations, creating some kind of entity and some kind of requirements for the capacity of that entity to demonstrate that they can provide, that entity can provide the totality from their people that work within the organization, staff or contracted, the totality of palliative care services that are listed as the services we're talking about here.
Okay. Great. So as we dive into payment models, hopefully you've been able to read some of the information here. The Center to Advance Palliative Care recently completed a national initiative to identify community palliative care programs and reported that fee-for-service or a fixed periodic payment were the two most common payment arrangements. And so the next few minutes, I just want to compare and contrast some of the pluses and minuses about each of these approaches and save a few minutes for feedback because I know that you probably have opinions on what you'd prefer to see. So in the fee-for-service model, we know that that's been around for a long time. The operational complexity is low, and each provider is reimbursed based on the specific HCPCS code that they file to identify those services. From a payer perspective, the fee-for-service model ensures that a payment is made only when the service is rendered. And considering the variation in patient complexity and palliative care service needs for eligible patients, this approach is sometimes appealing for payers because, again, they're only paying for what is rendered. From the provider perspective, there may be a concern for insufficient compensation for these services. Providers may be incentivized to just do more volume, see more patients, to have more patient encounters, rather than really expanding their resources to manage the patient's needs in a more effectively and efficiently manner. Sometimes payers address concern for overpayment using prior authorization, or quality performance requirements. California's Medicaid program, for example, is a fee-for-service model for palliative care services. I know that there are some opinions on fee-for-service, and I also wanted to point out that in the last few years, there's been more use of time-based care management codes. So there has been improvement in the ability for providers to be compensated for the time that they're spending with these patients. And so before we go into the periodic or the fixed payment model, want to pause and just get your gut reaction to fee-for-service or whether that's even on the table for your benefit development.
So I am going to interject real quickly here and say that I believe the way that we have structured that we're taking the direction from the bill and have structured the contract with Milliman is we are considering fee-for-service and then at least one alternative payment model.
Okay.
So yes, want to hear everybody's feedback, know that there are a lot of very informed opinions about the experience with fee-for-service, but that's kind of where we have it set up with the bill. Go ahead, Jennifer.
All right, so the dark horse, I am from a payer. And we have been really exploring how palliative care is reimbursed internally. And we do have kind of a hybrid fee-for-service plus, something else, care coordination fee. I do think that I liked, like the little bit of risk talk that we had later on in the document, because I do think there are just from my history, I want to say there are some large challenges with fee for service reimbursement of palliative care. And also, I feel like we make it really hard for palliative care programs to grow in a fee for service environment. So I just want to like give that feedback because I think, they're doing a lot of things that are outside fee for service building things like chaplain, some of the social work codes, some of the other things that they're doing are outside of the fee for service. So I'm not saying like it's off the table, but I think if we do go fee for service route, we have to look at really um, something else, some other reimbursement along with that. So I just want to get that
Okay.
out there. Yeah.
Thank you. So with the periodic payment, or this might be a fixed, providers are reimbursed a fixed amount for palliative care services for a predefined period of time. This may be a single day, such as the hospice daily rate, 30 days, or an extended period, such as 6 months. And the fixed reimbursement can vary based on prospectively estimated or like a retrospective determined based on the patient complexity. In the periodic payment model, the palliative care provider can control the type and amounts of services. So this sometimes is considered like they have more flexibility in the services that they're providing and allocating resources more efficiently so that they may spend more or less time on staff time versus care coordination and really can meet the needs of the individual patients in a more flexible way than fee for service. With the fixed reimbursement model, there may be an incentive for providers to underutilize services in order to maximize their revenue. So, for example, providers may gatekeep services or delay disenrollment when clinical eligibility are no longer met to continue to gain that kind of fixed payment. And so, with those examples, PASI, so the American Academy of Hospice and Palliative Care Medicine, has a payment model where they have a tiered, equally weighted monthly care management payment based on patient complexity. And then there's another model called Palliative Care Support to a Medical Home, where they offer an upfront fixed payment to cover the assessment, the initial getting to know you, an initial assessment, followed by lower fixed monthly support fees. So the hybrid approach can be done with the way that you're distributing the dollars, either with monthly fixed payments or an upfront payment, or a hybrid of some services are rendered fee for service, whereas others are being kind of captured in a monthly PMPM. And so all of those options are on the table. And I know we're running out of time. And to Carol's point, it kind of links with how you're going to set up your providers, whether you're going to use established palliative care teams or hospice agencies, or whether you're going to allow individual providers to also render palliative care services in a select palliative care services. And so I am going to pause and let the group kind of discuss the pros and cons. And if there's any guidance that you want Matthew to have in the analysis, we would love to hear from you now.
This is Jennifer. I guess one of the things as I work for the Washington State Hospital Association, and prior to this role, I worked in a critical access hospital in value-based contracts. And so I think from a provider perspective, one of the things that I think works really well anytime you're looking at an alternative payment model is the ability to have the blend of both a fee for service and a like a PMPM, like a per month per patient type of model, because hospitals or any type of organization is going to have a fixed cost in order to implement the program, irregardless of volume. The fee for service definitely incentivizes the volume, but to me, that seems to be the best blend for sustainability of a program and being able to implement this. So that's just my 2 cents to consider.
Thank you.
Go ahead, Mara. And I'm sorry we missed you on some of these earlier conversations.
That's okay. I personally like the palliative care support to a medical home with that upfront fixed payment to cover like the initial chunk of time you put into someone, especially if they're coming out of the hospital. There's a lot of work with med rec and getting them situated back home, and then followed by monthly support service payments, because then they're more established. They're, you know, we're getting into just settling them down and caring for them. I personally like that. And then paying for additional fee for service when there's additional ACP discussions and pulse discussions, like where are we now, bouncing back and forth from the hospital as often as you are, you know, those kind of conversations. So I think that to me, just it makes sense.
Great.
Yeah, go ahead, Barb.
Yeah, one other consideration is whether the benefit would require billing for if the person receiving palliative care does have Medicare Part B services. Would you be required to try to get funding from Medicare for whatever qualifies first? And if there's a denial for services that Medicare doesn't cover, for example, such as nursing visits or things, it just makes it cumbersome if every bill has to be submitted to Medicare for denial first before it could be reimbursed by a payer for palliative care. I don't know if I'm making myself clear, but it adds complexity to the provider's billing process.
And one thing I would just like to leave the group with, since I know we're starting to get close to time, is any additional specificity you want to provide around how you view this in your comments and questions would be helpful. In particular, one of the things we mentioned earlier was this notion of getting a total cost of care model where providers may be taking on risk. I don't think that necessarily really works in a fee-for-service or a fee-for-service plus, where there's like 90% of it is fee-for-service and they have this little plus. I mean, I think that's the sort of thing where you probably do want to have something in terms of somebody is taking on the full risk of this and the provider is now, or like 95% of the risk if we want to carve something out for whatever reason. But I do want just some thoughts on how you envision that, because I do think that to the extent that overall cost is a concern, having a clear vision on how you think something like that would properly function, I think would be helpful. So any additional comments and guidance you can provide on that, I think would be helpful and appreciated.
Okay, and it's 10:59. We're coming up on the end of our hour block here, but we've had a lot of really good discussion. Suffice it to say, we're going to be considering these comments. I put in the chat that I'm going to be giving everybody 2 weeks to review what Milliman has put together and reflect more on our conversation today about payment models and what we'll assume for this analysis. Very much invite you to write that to me. I'll share it with Milliman. We're also going to be discussing this more with Milliman and our partners. And so, you know, we'll reach out accordingly to the extent we really want to bring sort of more of these decisions to the work group about what we're assuming. But really appreciate the comments. So again, there will be a future work group meeting where we're planning to go over the actuarial analysis, a part of Milliman's work. We're working on scheduling that since we've been really trying to get Milliman into the all payer claims database and dealing with a tight time frame. We don't have that on the calendar yet, but we'll be trying to do that relatively soon. So again, please send us your feedback. My email is in the chat. Reach out with any questions. Thank you for everybody's comments and input today.
Thank you all.
Thank you.
Thank you all.
Thank you.
Thank you.